Well, welcome to session 5 of the first day of Rio, where the focus is ablation strategies for persistent AF. I'm delighted to be again joined by our panel and our presenter for this session, Christian Veltman. Christian, it's over to you.
Yeah, Richard, thanks. Thank you for the introduction. So we switched the topic from pacing to ablation strategies for persistent atrial fibrillation. Here you see my potential conflict of interests. So when we talk about persistent atrial fibrillations, we may have or we may face different mechanisms which are causing which underlie the persistent atrial fibrillation. So of course we have shown in red the foci, like ectopic foci, primarily in the pulmonary veins, but also in the right atrium, the SVC, the CS ostium, and also the triggers from the appendages on the right side and on the left side. And also what we see are the role of the autonomic system, like ganglionated plexi, and of course in the light blue shown we have some rotors causing atrial fibrillation and supporting persistent atrial fibrillation. And of course we may face some macro re-entry circuit around the roof, around the tricuspid annulus, so the tricuspid valve, around the mitral annulus or the roof of the left atrium. So, and the major problem in my eyes is in most patients we do not understand the underlying mechanism of persistent AF in this particular patient. So, when we look at how good we are to get the patient AF free 12 months after ablation, and this is a meta-analysis published 2019, we see around 50% are free of atrial fibrillation after 1 year. And if we look after our surgical colleagues, they publish success rates of around 70%. So why is that? Of course, there are potentially different patient populations. Of course, there are different ablation strategies used in all these publications. And of course, we have different follow-up methods. So surgical follow-ups are, in my opinion, different from cardiological follow-up of AF patients. So if we look at the AF guidelines with respect to catheter ablations, we see the cornerstone of AF catheter ablation is complete isolation of the pulmonary veins. But there might be, of course, more things to do or more strategies to do to treat patients with persistent atrial fibrillation. So what we can do is defragmentation in the left and the right atrium by ablating of cafés. We can apply linear lesions. We can perform box isolation of fibrotic areas, the BIFA. And of course, we can do, published last year, I will show you later, the ethanol infusion in the vein of Marshall. We may isolate the posterior wall. We can go for LAA isolation to isolate triggers coming from there. Of course, CTI ablation, right atrial lesions, SVC isolation. And there are also strategies going for epicardial AF ablation in patients with persistent atrial fibrillation. So the question is, who needs or do we need additional lesions beyond PVI and persistent atrial fibrillation? And if you look at this first patient on the left-hand side, you see nicely isolated pulmonary veins and a completely healthy left atrium. So there's no scar, no low voltage in the left atrium. So probably this patient does not need more application, RF application in the left, at least in the left atrium. But if we look at the next patient on the right-hand side, we see also again the isolated pulmonary veins and a quite healthy posterior wall, but a very diseased anterior wall, and also the roof is diseased. So we see low amplitudes, fibrotic tissue, and I think everybody agrees that this patient may need further ablation strategies to keep him in sinus rhythm. So there were studies performing PVI only versus defragmentation in patients with persistent atrial fibrillation. In an early trial published from the Hamburg University Center in 2015 was the strategy to randomize patients to PVI only to defragmentation. So, and here you see the strategy in the defragmentation arm, patients undergoing pulmonary vein isolation, and then they put further steps: LA defragmentation, CS defragmentation, RA defragmentation, and then they got atrial tachycardia in 27 patients, and they tried to map it and ablate it to gain sinus rhythm, either by termination into sinus rhythm, or, and you see here, 41 out of the 75 patients need to undergo electrical cardioversion. What you see in this study is that the procedure time was much longer if you go for this defragmentation approach. Radio frequency time 100 minutes, so a long procedure with long fluoroscopy time. So this is the price we pay if we do more than just PVI. On the other hand, same experience then you see the outcome of this trial, and you see there's no difference if you do PVI only or this complex defragmentation procedure. And the same experience, the colleagues from the Professor Cook's Institute had the same experience. They had a similar or quite similar approach, randomized 128 patients with long persistent AF 1:1, and you see here after single procedure, no difference between PVI only strategy and substrate modification therapy. But if you look at multiple procedures, you see that it might be beneficial, and you see here that patients who underwent repeated procedures undergoing substrate modification had less AF recurrences than patients who were only undergoing PVI isolation. The multi-center trial, I think I don't have to show you because this is already known. Also in a multi-center approach was shown that PVI isolation only was not superior to isolation plus ablation of fractionated electrograms or doing empiric linear lesions on the left atrial roof and the mitral isthmus. So what are further strategies? I already mentioned the Venus trial. So this is published last year, and the colleagues were doing catheter ablation, whether it's catheter ablation for atrial fibrillation plus ethanol infusion in the vein of Marshall. And there were 343 patients randomized either to catheter ablation alone or to catheter ablation plus ethanol infusion. And what they could show is that the patient undergoing additional vein of Marshall alcohol infusion had less recurrences than the patient undergoing only catheter ablation. And on the next slide, you see that the burden of AF, which is, I think, a very, very important outcome parameter, especially in patients with heart failure, you see when the patients had additional vein of Marshall ethanol infusion, the burden was much lower than if the patient underwent only catheter ablation. Going further, this is the strategy of isolation of fibrotic tissues in patients with persistent atrial fibrillation. You see here that if you see an area of fibrotic low amplitudes, you try to isolate it. It is the box isolation of fibrotic area approach, which might be beneficial. And in the last slides, I just want to show you the results of the DCAF trial. I think a very interesting approach. Patient underwent MRI to identify areas of fibrosis, and then the patient were randomized either to an arm where the electrophysiologist had access to these MRI data and was asked to isolate the pulmonary veins and isolate and ablate these fibrotic tissues. and on the other arm, there was only a PVI performed. Patients underwent again an MRI after 3 months, and the endpoint was atrial arrhythmia recurrence. Unfortunately, this approach did not, or the MRI-guided approach, did not lead to a reduction of atrial arrhythmias after ablation compared to PVI only, and quite disappointing, especially for the study group. But then they looked at only mildly diseased patients, so with less than 20% of left atrial fibrosis. And if you go for ablation in this subgroup of patients and you are able to ablate a lot, so more than 60–80% of this fibrotic tissue, there was a benefit with respect to AF recurrence. But we have to say, or we have to admit, that in the MRI-guided approach, so the more extensive efforts to treat atrial fibrillation, there were significantly more strokes and TIAs, whereas in the conventional PVI group, there was no single stroke or TIA. So the more we do, the higher the risk, of course, for complications. On the last slide, I want to show you this endoepicardial ablation for persistent atrial fibrillation. So this is a strategy Christopher Piokowski from Dresden published in 2018, and 59 patients with durable PV isolation underwent in the second or third procedure biatrial endo and epicardial sinus rhythm voltage map, and then they identified targets for ablation. And what they did find is that in 14% of the patients, they had epicardial low voltage and only epicardial low voltage, and they found in 90% epicardial conduction abnormalities. However, ablation endocardially and epicardially led to a recurrence rate of only 20% in this patient of atrial fibrillation. And similar results were published this year in JCE. You see less patients, and this approach had endocardial ablation, epicardial ablation in a single procedure, and you see here similar success rates in this quite small study. So I like to, before I summarize, I have to say to talk about pulse field ablation and persistent AF. And what you see here is, this is a study by Vivek Reddy. 25 patients underwent pulse field ablation for PVI, isolation of the posterior wall and the CTI. And this was a very safe approach. They had no complications, and they had high success rates acutely and also during follow-up. So only one patient had a recurrence in PV connection, but the posterior wall was isolated in all the patients. So this is a very interesting and probably also safe approach to target persistent atrial fibrillation. So in summary, PVI is the cornerstone in persistent atrial fibrillation, whether you do it point by point and RF therapy or single shot devices, cryo RF or PFA. I think, in my opinion, it doesn't matter. Application of additional lesion in the first procedure are questionable in my eyes. We can discuss it. And interpretation and execution of additional ablation strategies, especially defragmentation, is different in all the centers, but an individual approach to each patient seems reasonable, as I showed you, depending on the voltage map in the left atrium. New technologies like PFA or ethanol infusion of the vein of Marshall offer standardized and potentially safe approaches to ablation of persistent AF. However, we need multi-center trials with very clear and applicable application strategies and close follow-up monitoring to show that additional lesions in patients with persistent AF are beneficial. Thank you very much for your attention.
Wonderful summary. Thank you so much, Christian. Let me maybe ask the other panelists, starting with Helmut. Do you think that there are any saviors for persistent AF ablation? What's the strategy that's going to solve this problem for us?
two ideas at the moment. The first idea, I have my first experience with PFA in persistent patients, and I think it works nicely. And I think the technology of PFA is promising because you spare the extracellular matrix. And if you spare that, then this is another type of an ablation lesion, so that you really target the myocardium and not the rest. And I think this could rewrite the literature, especially with regard to posterior wall isolation. That's one idea I have, but of course it has to be shown. Vivek Reddy has shown his series with 25 patients, that's not much. And of course, there is studies going on, and I've been involved in one study, the Medtronic Pulsed AF study, and we are evaluating these persistent patients in the study. And the second thing I think is, of course, we need randomized controlled trials, and STAR AF3 is now going on. And I have the privilege with my center to take part in, where there is three groups, the PVI group, an electrogram mapping group, and the posterior wall isolation group. And we will see what this is worth, how it goes. So these are my two ideas.
And Pugas, what do you think? What's the saviour for persistent AF?
What is the?
So, Dr. Vijayaraman, what do you think is the answer to this?
Yeah, so if you know that we'd be in a different place right now for persistent AFib, it's a struggle. So when the firm ablation came on, we all latched on very quickly, trying to see if that would be our savior, and we failed miserably. And so I think we're still waiting for the real good randomized trials to show us any particular strategy would be better. So the vein of Marshall ablation seems to be a little bit more promising. And so I think the persistent AFib we still haven't been able to classify the type of patient. There are a good percentage of patients that'll do very well with just PVI alone for a long time. So I think we need a randomization strategy as what should be the second procedure post PVI isolation when they come back and the veins are all isolated. What is the best strategy? I think that's our approach right now, is to do PVI and then wait and do whatever we currently do, all this potpourri of different approaches. So right now we are still where we were 10 years ago.
And Christian, can I ask you, the audience has asked for you to comment on what you think about AI-based mapping technologies for persistent AF.
Yeah, I think, this of course, if it works and it really guides us to do like beneficial ablation lesions, then I think it is very promising, or would be very promising. But what I think is the problem is, if you have, like, as I mentioned, this defragmentation approach, this is interpreted by every electrophysiologist in a different way. And then you say, when you read the trials, somebody says, okay, first step, I do defragmentation in the left atrium, and then in the redo procedure, I do again defragmentation in the left atrium. So I'm not clear what the real endpoint for this step is. And I agree with Puga. I think we need really standardized procedures like PVI isolations, because we can control it and we can test it. And we need, for example, like ethanol infusion in the vein of Marshall. This is a procedure everybody can follow, or SVC isolation. So I think there are clear endpoints what to do, or box isolation of the posterior wall, probably doing with PFA, which is quite promising. So what I think is we need clear procedures which are interpreted and performed similar in all the centers, and then we can compare the strategies. But AI, at the end, to come back to your question, I think this is a promising tool, but as Helmut said, it has to prove in multi-center trial that it really helps, yes.
And can I ask you all, To give a yes or no answer, does any one of you do anything other than isolate the pulmonary veins on your first persistent AF ablation procedure?
Yes, so in our center, my first approach is I would do PVI, linear roof ablation, and then right-sided flutter ablation on all patients that come for persistent AFib. I mean, I don't have data to support that should be done in everybody because of our early experience with some patients coming back with flutters. At least we can eliminate the CTI flutters. And secondly, I'd like to do the roof line as a first during the first procedure, because if they do come back for redo AFib, then I know that the roof line is still good and I can complete a posterior wall isolation that may be more durable than if I give chance for 2 new linear lesions with a higher chance for gap conductions coming back. So that's my approach, not based on outcomes or anything at this point.
And Helmut, do you do anything other than PVI? And if so, who do you pick for doing something more than PVI?
Right. If I'm using a 3D system in persistent, because in some patients, if this is short-lasting persistence, I use cryo as well. And then, of course, there is no 3D map available. In others, if I use a 3D system, then in 90% only PVI. But if there is a clear scarring of the atrium, I try to do 1 or 2 strategic lesions based on the scarring I see. So to connect, for example, a scar with an anatomical border, like the mitral valve.
So it's based on scar and the presence of scar. Is that true for you as well, Christian?
Yes. So my approach is close to Helmut's approach. We go for PVI and in many patients also with single shot devices. But if we do in 3D mapping, then we do strategic lesions. So if we see the roof is sick and we see by the pulmonary vein isolation lines, we see that we only need 2 or 3 more shots to close up the roof, then we do it. And then we do a strategic line, usually only on the anterior side, because we don't want to go on the posterior wall because of this problem with the esophagus to avoid complications.
Great. Well, I'm afraid that's all we have time for in this session. Our thanks again to Christian for a fantastic talk. And many thanks to our panel, Helmut Perfellner and Pugazendi Vijayaraman, for their wonderful input. This is the last session of the day, but before we go, we've got a review of today's proceedings. I'd first like to start by thanking the many thousands of the EP community around the world for attending this Rio live session. We've seen plenty of highlights. We've seen very high power, short duration PVI under mild sedation from Dhiraj Gupta, showing that you can isolate the pulmonary veins in a very, very short time. Cryoablation of atrial fibrillation with concomitant left atrial appendage occlusion from Julian Chun and Boris Schmidt, showing us that the two can be done in one sitting to give the patient an incredibly convenient and complete treatment package in one go. And then we also have seen leadless pacing and AV node ablation for patients treated with ablative pace strategy by Devi Nair. And one thing that I really reflect on is how much electrophysiology has changed in the 20 years or 30 years that I've been practicing. We started off spending 12 hours doing AF ablation, and now we're seeing live cases done in much less than an hour. However, we've also had some really important reflections on the fact that ablation and intervention is not the only answer, and that thinking about the risks of the patient and improving those will really improve the outcomes of procedures. And then we've finished off on the very difficult question of what we should do for ablation of persistent AF, and Christian and the panel really giving us some important insights on how we might manage those patients. I'd like to thank our panelists for their insights, but I'd also very much like to thank our sponsors who made this free-to-access intervention program possible, the headline partner, Boston Scientific, and our supporting partners, Abbott, Biosense Webster, and EBR Systems, and our educational partner, AtriCure. This is just the start. We've got 2 more days from tomorrow at 4 p.m. Central European Time, so please be sure to join us, and thanks again for joining us today. Goodbye.